Good afternoon, everyone, and thank you for Zooming in with us today. I am Ruth Katz, Vice President and Executive Director of the Health, Medicine, and Society program at the Aspen Institute. I'm delighted to kick off today's webinar, which is co-hosted by the Health, Medicine, and Society program and the USC Schaeffer Center for Health Policy and Economics. Now, we'll get started with our speakers in just a moment, but first, let me set the stage for today's discussion. Health Technology Assessment, or HTA, is a tool that, when designed and used effectively, can provide critical input for decision makers about product price and product value, while also recognizing the contribution of innovation to advancing health and health care. But unlike other advanced nations, the United States does not have a coordinated process to evaluate the effectiveness and value of new devices, medicines, or procedures. The Schaeffer Center and the Aspen Institute believe this is an issue in need of examination and recommendations for how best to proceed. So in 2019, our institutions partnered in convening an advisory panel to determine whether and how the United States might implement a value assessment process for medical technology, a process which also would ensure a sustainable health system that supports innovation. The panel includes 19 experts representing broad views on the topic, including those from academia, government, and industry, as well as patients and payers. 3 of the panelists are international experts from countries that have publicly funded HTA organizations. At the conclusion of its work, the panel published a white paper outlining the group's 6 recommendations, including the creation of a new entity, the Institute for Health Technology Assessment. To learn more about the panel's recommendations, we are pleased to be joined by its 3 co-chairs who will lead off our webinar today: Darius Lakdawalla, Peter Neumann, and Gail Wilensky. Darius Lakdawalla is Director of Research at the Schaeffer Center. He also holds the Quintiles Chair in Pharmaceutical Development and Regulatory Innovation at USC's School of Pharmacy. Peter Neumann is Director of the Center for Evaluation of Value and Risk in Health at the Institute for Clinical Research and Health Policy Studies at Tufts Medical Center. And Gail Wilensky is an economist and senior fellow at Project Hope. Before joining Project Hope, Gail directed the Medicare and Medicaid programs and served in the White House as senior advisor on health and welfare issues to President George H.W. Bush. She also served as the inaugural chair of the Medicare Payment Advisory Commission. Darius, Peter, and Gail will be in conversation with today's moderator, Rachel Cohrs, Washington correspondent for STAT, reporting on the intersection of politics and health policy. Rachel previously covered health policy for Modern Healthcare and prescription drug pricing for Inside Health Policy. Welcome, Rachel. Thank you. Great to have you here. And thanks to all our co-chairs for leading the Schaeffer Aspen effort and for taking part in today's event. Finally, I want to thank again all of you in our audience for your participation. We think you're in for a really thoughtful and certainly a very, very timely program. Thanks again to everyone. And Rachel, the Zoom screen is now all yours.
Thanks so much, Ruth. I appreciate it. So in this first panel, we're going to be kind of talking about some of the recommendations and just getting a more full kind of perspective on kind of where the panel landed on the future of health technology assessment and the potential involvement of the government in that process. So to open things up, I'd just like to open the floor to our panelists to start with kind of what problem or what kind of void were you trying to fill when you were kind of debating recommendations for the white paper?
I think the way to look at this issue is we were trying to deal with what could such an advisory group, what it could do, what it has to do, and what it can't do. And let me explain that briefly. What it can do is be advisory to payers, public and private, about the value of new technologies and the circumstances in which they seem to be effective. What they must do, as far as I'm concerned, is realize that the focus exclusively on medicines is a mistake. It's a mistake because it misses too much of where the spending is. And that if this is going to have a chance to succeed and to be taken seriously, and as well to be successful, it needs to take a broader look at technology in terms of procedures and interventions. What it can't do is attempt to be determinative as to what can or cannot be made available. So providing information about the effectiveness of new technologies, broadly speaking, not just focusing on the 10% of the health expenditure spend made up by drugs, and providing information that public and private payers can use would be an enormous addition. It's when it attempts or think it should attempt to step beyond those boundaries that such a center might get itself in real trouble.
Building on Gail's comments, Rachel, I think that the reason that we have such a tightly focused health technology assessment literature in the United States is by relying on private funding. Naturally, it's going to produce information relevant to the private funders. And other kinds of interventions that are more broad-based and the stakeholders who benefit from them, like let's say we're looking at surgical procedures or delivery reforms that don't have a patent holder, but many patients benefit from good information about it. Many delivery systems, health insurers benefit. Those are going to be really hard to fund in a private system. And since information is a public good, there is a natural role for government, not instead of a private system for developing HTA information, but in addition to, and in order to improve upon the private system that we have today.
And I would just build on those comments in a few ways. One, to emphasize, and the white paper does, that this information is a public good, but we also emphasize that there are existing private HTA efforts in the United States and that they should continue. And that this body ideally should help fill in the gaps and not duplicate efforts, but really add to and complement the efforts. The other point we make is that there are existing public HTA type activities in the United States today, but for a variety of reasons, we believe that there's value in having an additional body devoted to this effort and focused really particularly on health technology assessment in the way that some of the other groups, for example, PCORI and others, are not doing today.
Yeah, absolutely. I'm glad you mentioned PCORI, just because there have been, prior efforts to, have some sort of health technology assessment within kind of the government, and not all of those efforts have been successful. PCORI is doing comparative effectiveness, which sort of has a different goal, but it's kind of in a similar space. So I just wanted to give each of you kind of an opportunity to kind of talk about where we've been and what you all, kind of the lessons that you learned in kind of what would need to be done differently if there were going to be some sort of public HTA board.
Well, we don't want to repeat the mistakes that we have gone through before. And I think it means to be very clear that this is advisory. It is looking at technology broadly defined. So this is not, as is frequently the case in many European countries, entirely or primarily focused on pharmaceutical products, and to recognize that the effectiveness of a technology may differ depending on where it's performed, who's doing the performance, and the subset of individuals that are receiving the value of the technology. This is an area whereas Peter was just commenting on, there is a close relationship, or can be, between comparative effectiveness work and technology assessment, recognizing that it is technology broadly defined, and that you may need to distinguish between the effectiveness for a particular subset of individuals or a particular demographic group. It is relatively rare that a technology will be always effective or never be effective if it has received any kind of regulatory approval, FDA or otherwise, and trying to understand the circumstances in which it will be likely effective really could use some additional resources. That's something we might be able to not only tolerate, but at least parts of the population actively embrace in the United States.
I think that turning specifically the question about what's the role and differentiation compared to, let's say, PCORI or other agencies, I think that it's important to emphasize that health technology assessment is always a fraught exercise. There are a lot of competing interests involved, and different perspectives held by different stakeholders, whether it's different kinds of payers, public payers, private payers, different kinds of private payers, patients, physicians, et cetera, et cetera. So when you combine value assessment or health technology assessment with an agency that has other remits or other kinds of responsibilities or obligations, it creates more potential for conflict of interest or of focus. Even if it's not a conflict of interest, it can be a conflict of focus. And we think that health technology assessment as an activity hasn't really gotten sufficient focus from the federal government in the past. And so that focus, I think, is unique and hard to overlay upon any of the existing players that have their own tasks to fulfill.
And just to build on that, we can think of different health technology assessment activities at different public agencies. PCORI, of course, but also CMS does certain activities, AHRQ, the VA, and others, but they tend to be focused narrowly on their populations or on their specific mandates. There's certainly a lot of work to be done. None of those agencies functions as a traditional HTA body, systematically evaluating technologies. I think it will be important, again, not to duplicate efforts and to build on existing efforts. And as to Gail's point, to focus on poorly studied areas or under-studied areas, and particularly procedures and services and such, and perhaps certain diseases even that are not studied as well as they should be today. But the idea is that this would be a different kind of activity, and it would complement and perhaps supplement some of the existing activities.
Right. So I think that makes sense that, there's not any entity doing this precise thing right now in the government. But as I think we've kind of touched on a little bit earlier, there are some like private sector or nonprofit entities that have, started to that fill that void for certain evaluating purposes, certain industries, focusing on, pharmaceuticals. You have ICER. Like, what would happen to ICER? I mean, if there were some, public entity, how, would that coordination work to make sure, there aren't duplicated efforts? Or, do you think that could undermine kind of what ICER is doing and kind of some of the private sector efforts out there right now?
Actually, I think ICER is highly complementary with what we're proposing. That ICER, that we think there's an important distinction between the generation of evidence on health technology assessment and the evaluation of that evidence. But in order to be an objective reader or evaluator of the evidence, it helps that you don't already have a dog in the fight about which study is best. And so I think that an organization like ICER plays an important role in generating evidence, but it makes sense to decouple that function from the evaluation of it. And I think that's the reason why they would play well together, in my opinion.
In the past, when we've attempted as a country to take this on, there was concern about duplication between what various groups were doing. The way we have discussed this today is very much targeting an area that the three of us, as well as the group that we were associated with, believe is not being done today. And so, unlike the attempt in the 1990s, this is a very targeted, focused look on an area that is not getting the kind of attention it should in order for public and private decision makers to make more informed decisions, as well as clinicians and patients. So this ought to be the result of learning what we haven't done as well as we might in the past, and looking at what exists and seeing where the missing pieces continue to be important. So I think this would be something that, if done right and well, could be embraced by both the public and private sector as providing very important information that has been missing to date.
I would just say, I mentioned before, the white paper emphasized that private HTA efforts by all means should continue. I would certainly include ICER in that. There's more than enough work to go around here. Also, ICER has its particular methodology and its focus. It focuses mostly on drugs. It uses cost per qualities. It has its own processes and such. And by all means, all of that can continue. The other reality with ICER is it's a private body, and at the end of the day, it's has issues around, or at least questions it raises around accountability and legitimacy and such. Despite the good work it does, it's not a body created by elected officials. It's not a public body, and a public body would bring additional strengths because of it.
Absolutely. And I think now I'd like to talk about what kind of analyses the public entity could actually kind of produce, and kind of where the money falls on that. Because the recommendation is that these analyses would go beyond just the clinical effectiveness comparison and take into account a cost effectiveness comparison, but the economic analysis would be disaggregated. So it seems like that's kind of this middle ground between kind of having some sort of unified cost effectiveness metric and providing, no economic information at all. So I wanted to hear a little bit more about kind of how you all came to that middle ground of including a disaggregated economic analysis in the HTA kind of product that this public agency could put out.
Well, maybe I'll take a stab at this and then perhaps editorializing a little bit, but I think this was both a compromise of sorts with a committee of 19 people, but also an eye to political realities. That we did believe that assessment should include clinical and economic measures. That's a difference with the PCORI, focuses on clinical measures mostly. But the idea of endorsing a summary measure, cost per life year, cost per quality, was debated, controversial. I think again thought that in this political climate would be very difficult. So the recommendation, if you read the white paper, is to focus on disaggregated measures, disaggregated costs, and disaggregated clinical consequence measures, which we believe could be very important. We do say summary measures can be useful, but that the HTA reports would not be limited to them.
I think Peter's exactly right that there's a practical consideration. I also do think that there's a principled reason to do it this way, that we have a decentralized healthcare system with a wide variety of stakeholders that have different incentives. And so they actually care about different things. And in order to create a single index of value, however you do it, whether it's cost per quality or per life year or per heart attack prevented, whatever you want to do, that implicitly involves some idea of weighting different kinds of dollar figures or health dimensions in a particular way. And different stakeholders in our system have different weights. And so it seemed more appropriate to let that process of aggregation, if you like, happen in the marketplace rather than in a public agency that is supposed to serve a wide variety of stakeholders rather than a very specific kind of stakeholder.
We also believe that by focusing on the disaggregation, we are providing the hard to calculate information in a way that others, public and private payers, or others besides payers as groups, can look at and aggregate in ways that they believe are appropriate. So by proposing that this group would focus on the elements that are able to be assembled, and again, for me, critically important, get beyond just pharmaceuticals, looking much more broadly at technologies and technological interventions. We are having available the elements that need to be available for payers to make rational decisions in ways that's simply not been available in the country in the past. But we don't need to have this group do the aggregation. Once the elements are available, how you aggregate and how you weight is relatively straightforward. Complex in terms of the implications, but the actual mechanisms involved are quite simple and straightforward. It's having that base information available that is so expensive, and that, by the way, is really the public good. Once it's available, you want it available to any payer or any potential user so that they don't have to recreate that again.
Right. Absolutely. Yeah. Thanks for kind of building out the rationale behind kind of that that position. And I think, we have touched on just like practical considerations, political considerations. In the white paper, I know it was specifically mentioned that under your recommendations that this panel could potentially consider the QALY or quality adjusted life year metric, which has been very controversial in the past. I think PCORI is banned from setting thresholds kind of on that metric. On Capitol Hill, it's been sort of a lightning rod for just political considerations about kind of the government getting involved in this space. So, obviously that wouldn't be the only metric that could be considered, but I wanted to just kind of ask like why that metric was could potentially be included in any analyses from this body.
Okay, I'll dive into that breach. I think that's a really great question. It's an important question. I'm going to speak for myself briefly, and then I'll turn back to speaking for the panel. But I think that economists have probably not done a sufficient job of figuring out how the value of the QALY varies across contexts, across types of patients. And I think that's sort of a mathematical and a theoretical issue that needs resolution. It's not a question of deliberation or of policy. It's a question about economics and math. So I think there's hope for the QALY. I think we haven't done as good a job with it as we could have. And even in spite of its many strengths, there's more we can do with it. I will say though, and I think now I'll turn to the panels, representing the panel. I think that the bulk of our group felt that the QALY has many strengths as well, that it is a way of capturing a broad range of trade-offs in a single measure. And ultimately, a decision, it has to involve the monetization of health improvement. That's always going to be controversial and complicated. There's never going to be a simple way of doing that. And so I don't think that somewhere out there there's a fantastic strategy for aggregating all of these health improvements in a way that everybody can agree on. Rather, we thought the right strategy here is to let 1,000 flowers bloom when it comes to looking at the value of health technology. So report the QALY alongside other kinds of measures of benefit and let marketplace stakeholders decide how they want to use this. And some of them will be interested in the QALY and some of them will not be interested in the QALY. And that's a market decision more than it is a public sector decision. And that, I think, blunts some of the force of the public policy critique of qualities. And yet I think you're absolutely right to say it's a controversial question, but it's kind of the best we have for capturing these trade-offs today.
Yeah, I mean, health economists and others have been drawn to the quality, as Darius said, it gives you a single measure. But just to emphasize, it gives you a standard that can be used in an analysis to compare very different treatments and diseases. And if you want to allocate resources to maximize health, the quality gives you a metric to help you do that. So it's a way of valuing treatment gains or intervention gains that combines mortality, morbidity, quality of life, and so forth. It does embody some strong assumptions. There are questions about whether it captures what patients care about. There was questions about whether a cost per quality analysis discriminates against older people, against disabled people. Any metric that you're going to use will have its own downsides, to be sure. But I think with all of this as context, the panel felt to be useful, it would be wise to recommend disaggregated measures, not to have the focus solely be on the quality. And, as others have said, decision makers are certainly free to use the quality, and they have different incentives, they have different populations they serve, and so forth. So this, I think, was again, a little bit of a compromise, but I think a wise one.
It's also important to understand that when the component information is available on a disaggregated form, that allows different decision makers to put together this information in different ways for different purposes. I think the three of us, and I assume most of the people listening, have some idea about the controversial nature that has been associated with the concept of qualities used either in the United States or proposed in the United States or used elsewhere. It is a useful measure to go across different kinds of technologies, but it is really the decentralized information and the monetization of health that, once done, allows different decision makers to take potentially different views about the assessment of a particular technology. And that's what we think is so critical, is that we need to have available, with all of the technologies that have been coming on before, more information that tries to assess them and to make available to those who think it's appropriate or who want to use them a way to monetize their value across other individuals. But this is not an attempt to force that, nor is an attempt to exclude other kinds of analysis. It is a strategy that provides a lot of information that different users can use in different ways.
All right, thanks so much for the insight into that specific metric, which I think leads us really well into kind of the next kind of controversial issue that you all decided for your recommendations, which was to talk about kind of what role the decisions out of this like health tech assessment agency could have in payer decisions, especially in an agency like Medicare. And the white paper kind of says that these evaluations, these assessments should be advisory. They shouldn't be, necessarily mandatory, but that CMS or that Medicare should demonstrate that they, have taken these analyses into consideration when they are making very complex and important payment decisions. So I would just wanted to offer you all an opportunity to talk about kind of how you came to that decision that these analyses should be advisory, not mandatory. If the government is going to be investing money in producing them, why stop at an advisory opinion?
Well, I view our position on the advisory as being somewhat analogous to the role that comments are viewed when proposed regulations are issued by CMS or other agencies. and that is when the agency makes a final decision, a final rule, it is obligated to comment on how it is taken into consideration the various groups of comments that were received with regard to the proposed rule. Doesn't have to accept any of the comments. It simply needs, well, simply may not be the right word, but it does need to make it clear that they were considered, why and how they were considered, and then ultimately whether or not they were used or not used in the final determination. That's really, to me, the role that I have had in mind for this group. That is decisions about coverage and or payment, depending on who we're talking about, whether it's a public or a private payer, can make use of this information. They should indicate they were aware of it, they considered it, but it needs to be well within their scope of saying, we chose to make a decision that includes some of these elements, but not others, or in some cases includes all of the advice, and in other cases includes none of it, but to provide the reasons and rationale as to why that decision was made. That puts it in a very different position where the decision making is left where it should be, which is either in the hands of the public payer or in the hands of the private payer.
I would add to that by just going down a very practical path of questioning, which is if we ask ourselves, what about a mandate? The first question you have to answer is, what exactly do you mandate? And it turns out that the thing you have to figure out is how do you translate these disparate pieces of information, many of which are uncertain. So they have some confidence intervals about them. There's a range of values. So you've got to translate all of that somehow algorithmically into a mandated price. And it seems impossible to do that without taking a pretty strong stand on a number of issues, like how do we value each of these disparate elements? How do we feel about uncertainty? How much risk are we willing to take? Those are decisions that are they're, I think, basically impossible to codify into a single regulation or a law, and they are more akin to a private or a public payer making discretionary determinations about how to incorporate all of this information and come up with a price on a case-by-case basis.
That was well said by Gail and Darius. I'll only add, I think there was consensus in this case that among the group, the panel in general, that the HTA body should be advisory. We had debates about lots of other issues, but I think there was a feeling, for all the reasons that both Gail and Darius mentioned, that this should not be a regulatory body. This is an information disseminating body, and it's advisory.
Thanks so much. I think my next question is about kind of, if this is a public entity, then how does it get paid for? And I think there were some interesting kind of models that we've seen in other agencies that, deal with industry with user fees or sort of other funding models. But I know that just kind of capture, toward the healthcare industry or a bias toward more closely evaluating technology made by like patent holders, that sort of thing is a concern that was expressed in the white paper, which was how this would come to fruition. So I think my question for you all is kind of how should this be funded if it were created, and kind of what considerations are there to think about in those different funding models?
I guess I'll start. I do think we should think about the white paper as a kind of a roadmap and a blueprint with lots of details to follow and principles laid out, and discussion of critical issues, including funding. Certainly, we did talk about several models that would be possible. MedPAC, the federal coordinating centers, there may be others. We talked about the history of some of the agencies that have failed in the past, OTA, Office of Technology Assessment, for example, and strengths and weaknesses of different possibilities. The idea of user fees, I think, is something that is attractive in many ways. The idea of trying to remove this body from some of the regular political debates and appropriations debates is attractive. So I'm sure Darius and Gail have other thoughts, but I do think a lot of details around financing, governance, placement, stakeholder input, processes, a lot important issues that have to be worked out.
I think Peter is appropriately kind of open-minded here about how to fund. I think that we don't. I think that the user fees are attractive. We do want to insulate the agency as much as possible from the hurly-burly of appropriations, and independence is a core element here that we have emphasized. I also just want to make the simple point that health technology assessment in the scheme of the healthcare system is not a particularly expensive activity compared to actually paying for healthcare or paying for medical innovation. So I don't view, and this is part of the reason why I think we are a little more agnostic about how the funding would take place. The first order issue probably isn't coming up with sufficient money to generate a meaningful health technology assessment enterprise. It's all of the other issues that you raised about the complexities of independence and what would the scope of this organization be. So I think that I think we're open on that, and as long as it does not incentivize a ton of lobbying and conflicts of interest to the greatest extent possible, I think that's really the only constraint that I would see.
And I think there was general agreement that some type of a user fee made sense, but as both my colleagues have indicated, there are a variety of ways specifically you could fund this type of activity, and that was probably less relevant for us to comment on than what the function was, what it would do and what it wouldn't do, and especially the advisory nature of the activity for payers and others, and also the fact that it needed to go beyond pharmaceuticals. To me, those 2 points are probably the overriding issues as to whether this would be a useful entity or not. There are a lot of other issues that need to be dealt with, but for me, those are the 2 overriding issues.
And I think we are almost at time, but I think my last question is that the 3 of you chaired, a pretty large panel of experts that were kind of discussing these different ideas and trying to come to an agreement on kind of what the shape of, health technology assessment should look like in the future and how the government should be involved in that. So my question for you is, with so many, experts and so many different ideas and opinions, which were the kind of specific issues that were kind of the flashpoints that really sparked vigorous debate, and that you really had to work through to finally come to kind of the conclusions and recommendations that you did in the white paper?
I think it helped that we had an extremely collegial group of very smart people, and we're extremely grateful. And I think we've probably gotten too much credit relative to our other panelists in terms of the contributions made. I think that certainly you've touched on several of them already, Rachel. The question of how do you bring this information to bear in a marketplace is an extremely difficult and controversial topic. What should the role of the body be? Is there a role for mandates? And the question is, how do you at the same time, how do you ensure that an advisory body has impact and influence? And I think that we were trying to balance, all of us were trying to balance those competing considerations to come up with an advisory process that would actually be impactful, that people would have to take account of, think through, and also that it would be producing information that's valuable so that people would want to use it. I mean, part of that is important too, that it's less important to mandate if you're really filling a critical unmet need in the marketplace.
I think that there were differences of opinion about the political realities that we were facing. But each individual that was providing time to this group was doing so because they thought this was an important need that was not being fulfilled yet in the United States, and that are attempting to bring together people from diverse backgrounds in terms of our academic orientation or our political orientation or our general views about the role of government and regulation, to the extent we could come up with ideas that were satisfactory to this group of individuals, that maybe it would be helpful to the ultimate decision makers, either in the Congress or in the society at large, about how to try to take on these controversial but important decisions.
I endorse the view that it was a particularly collegial group, so that helped a lot. And certainly everyone had their own ideological views, but also we had a diverse group in terms of representation from industry, from payers, from academics with different backgrounds and views and such. So I agree with Gail. I think the fact that we were able to come up with recommendations that this diverse group agreed with, I hope not only a useful exercise, but I hope it has lessons for the broader debates that follow. And leave the document there for people to look at, and I hope it has some resonance and use down the road.
All right. Well, thanks so much to all three of you for your time and for discussing your hard work. At this time, we are going to transition to a reactor panel to kind of discuss the findings and the recommendations that the panel made. And joining us today, we have two very esteemed individuals. We have Lee Fleisher, who is the Chief Medical Officer and Director of the Center for Clinical Standards and Quality for the Centers for Medicare and Medicaid Services. He is also a professor of anesthesiology and critical care and a professor of medicine at the University of Pennsylvania Perelman School of Medicine. Lee is an elected member of the National Academy of Medicine and was a former member of the Medical Advisory Panel of the Technology Evaluation Center of the Blue Cross Blue Shield Association. Welcome, Lee. And we also have Adrian Towse with us today. He's the Director Emeritus of the Office of Health Economics in the UK, where he joined the OAG in 1993 and served as Director for 25 years. As a Senior Visiting Fellow at the Health Economics Research Center, Newfield Department of Population Health at the University of Oxford. He previously had visiting professorships at the University of York and the London School of Economics. He's the president of the International Society for Pharmacoeconomics and Outcomes Research, the largest global professional society of health economists and outcomes researchers for the 2014 and 2015 term. And for 10 years, he served as the non-executive director of the Oxford University Hospitals NHS Trust, one of the UK's largest hospital groups. So welcome, Adrian, as well. I think we have everybody on here. So I believe we're going to transition to just some brief remarks from both Lee and Adrian. And I think, Lee, you are up first.
Great, thank you, and thank you so much, first of all, for doing this. It's an excellent report, and my colleagues in the coverage advisory group who helped me prepare some thoughts, and as well as myself, having been a former EPC-funded investigator from ARC, it's great to see how you're thinking about technology assessment, I'll say 20 years later. And CMS always welcomes health technology assessments of any technology, especially ones, as you've outlined, which would minimize bias or stakeholder influence. And we feel that any information that's reliable will be beneficial not only to us as payers, but importantly to patients, caregivers, and the clinical teams. And it really would be beneficial also from the perspective and from my former perspective on the Blue Cross panel of really better defining the outcomes and the populations, the PICO question, so to speak, for what technologies would need to actually be approved. So I think it really, some of the foundational questions and the foundational suggestions of the white paper are very helpful. Now, just for background, fee-for-service Medicare is a defined benefit. So first, we actually have to look at whether the new technology, whether it be a drug or device, really fits within our statutory definition. As you said in your white paper, we do have the authority to include health technology assessments in our national coverage decisions or our local coverage decision analysis. So we are reviewing, and we actually look for this. So even if this was created outside of the government, we could look to this to actually help inform our thinking about a new technology. We also use, and just from a model perspective, since I know Adrian's going to talk about this, like the U.S. Preventative Task Force, screening and prevention recommendations will impact national coverage for all payers. And for Medicare, we are statutorily obligated to review those recommendations. And through our national coverage process, we review them and explain why we are adopting or not adopting. So that final recommendation of this is not a decision-making body, but a decision-informing body is how, if this was created, how we would do it. The one key thing that's a big difference, as was sort of described and discussed during the panel, is the issue of cost and qualities, and has been mentioned by several of the panelists. We can't include cost in our coverage determinations, with the exception of prevention and screening. So if this panel were to start and do cost, and again, we like the idea, and I personally like the idea of effectiveness first, that the good place would be where we could use it, which is in prevention and screening. So just to finish up, there is a formal process. The 11 months that I've been in the agency, I've learned it. And you had Dr. Wilensky, who certainly knows it well. So we issue a public notice that we're reviewing a technology. We issue a national coverage decision within 6 months of opening up that review, where we could actually take into account external technology assessments. We then have to go through public comment, and 60 days after the public comment, we can issue a proposed final or national final coverage decision. So I hope that provides some framework of how within the program of CMS, we could use this work, and I'll turn it back to you, Rachel.
All right, thanks so much, Lee, for those comments. Adrian, I think we're going to hear some opening remarks from you as well.
Great, thank you. So thinking about the proposal from an international perspective, I want to make a couple of points. The first is pluralism, that emphasize the competing private plans, different public programs, all with different approaches to paying for drugs and other technologies. In most other countries, even where there are competing plans, for example, Netherlands, Germany, Switzerland, the assessment of drugs is centralized and the government oversees it. It's typically a committee led by health insurers, but operating within a legal framework of rules devised by the government. So it's immediately hard to draw parallels with other countries. But one analogy I think might be relevant is the European Union process, where for 15 years, member states have been working through a network called UNETA to get a single clinical assessment to avoid duplication. And this is about to be put into law. It's a Commission proposal before the European Parliament. But the key point is that this is only clinical, and the member states make their assessments of value for money via cost effectiveness or therapeutic value added, depending on the process they use. In this respect, I think there are similarities with the approach that's being proposed in the white paper to leave the cost effectiveness role to private and non-governmental entities directly supporting payers. I'd also note that the post-launch evidence generation component of the paper, one of the issues that's highlighted for the new agency to pick up, has been a significant strand of UNETA's current work program, although it's not clear how it will be enshrined in the new legislation. But one key point here, I think, is timing. So the European clinical assessment has to be ready in 30 days after European Medicines Agency licensing, our version of the FDA. So the national payers can then move quickly to do their own value assessments and potentially reimburse. And the second point linked to that is to be clear about who are the customers. And of course, as I've just said, the unique thing about the US is the complexity and the numbers of customers that you've got in terms of plans, payers, and providers. I would endorse the public good point. Interestingly, I noticed it was made by Uwe Reinhardt in his 2004 Health Affairs paper, where he was arguing for a federal network of independent research institutes or a federal agency for pharmacoeconomics. But to be effective, the agency has to be impacting decision-making. So in a sense, what is the information that's being undersupplied? And I know that the authors gave us some indication there. But what I think the point I would try and reinforce is the first generation of HTA bodies around the world, and it may be that OTA fitted into that category, generated worthy evidence. It took them several years to do it, and it was pushed out there. But it wasn't clear there was a customer who was then going to act on that evidence, whereas the current generation of HTA bodies are more focused, they're more customer-driven, they have a remit that's been given to them. So it's incredibly important that the information generated is being used and the focus is on what the plans and others, the providers, actually want to hear about. In the context of drug pricing, then this critical question of how the agency is going to ensure that there is evidence, good evidence, to inform decision-making by both public and private payers. So I think the proposal to support the work of ICER and other groups advising plans seems to be a good one. But there is no international precedent that I'm aware of for this sort of role in an HTA setting. Of course, that doesn't mean it can't be done. And indeed, I'm sure there are examples in other regulated sectors of the economy. But I would say that rating the quality of each HTA report produced in the private sector may not be realistic because of this question of timing. Remember that clinical assessment report in Europe has to be ready within 30 days for the payers to make decisions on that basis. I think if the issue is more general about healthcare dollars more broadly, then still it's critical that the services that matter are being tackled. We see this in NICE, which is one of the few agencies that does have an appraisal process that's not just about drugs. But it has to focus on the technologies that are referred to it by the government. And in practice, that's been primarily pharmaceuticals. It does have a diagnostic assessment program, which is set up, and it's set up with a major clinical guideline development program, which continues. And it's also assessing public health and social care interventions. So it is a very broad-based HTA body, one of the most broad-based in the world. But of course, people know NICE because of the decisions it makes on pharmaceuticals. So I think there is a critical issue, I think, of how the pharmaceutical issue is being addressed explicitly. I know we heard some thoughts on that earlier. So in summary, two very quick points. We do need to recognize the complexity of the US system is extremely unusual by international standards. And that the critical thing for a new agency is that it's clearly, in a sense, it's not just pushing evidence. There is a customer base who are asking and going to use this evidence and actually change US healthcare as a consequence. I'll stop there. Thanks.
All right. Thanks so much for the remarks, both of you. I think that was a great kind of a roadmap for where we'll be going for the rest of our discussion. First of all, I do want to bring in kind of just the very timely real-world example we have before us in kind of very difficult decisions that payers are facing in the United States following the FDA approval yesterday of Biogen's new Alzheimer's drug And, there's been some controversy over kind of what exactly the clinical effectiveness of that drug is and kind of the price of it. And I think this is a great kind of jumping off point to talk a little bit more about, in a situation like this, kind of what role could some sort of public health technology assessment play, and kind of what are the considerations when we're kind of making these really hard decisions that could have financial ramifications for generations to come. So I think, does anyone want to start us off in talking about? No. I'm sorry,
I can't. We're still briefing the secretary and the administrator, so I'm going to stay quiet on this particular issue.
I'll just say a couple of things, and then it'd be very helpful to get Darius's perspective. But there are different HTA approaches here. So I imagine that the agency would potentially be going down the route that NICE would go down, and I think the route that ICER in conceptual terms would take as well, which is, how do we model based on the clinical evidence that we have? What assumptions is it reasonable to make about these surrogate outcomes? And what evidence do we potentially then get about the potential effectiveness? And then obviously the additional point being, what are the degrees of uncertainty around that? Should we make some sort of conditional price or conditional approval? Are there trials or additional evidence collection in the way that's going to address those uncertainties so the decision can be revisited? I mean, it's worth, I think, saying that by contrast, some international agencies are purely driven by the clinical evidence, in which case their willingness to endorse the product on the basis of more limited clinical evidence would be less. But so I think a lot depends on whether the assumption behind the agency is it's going to make the best of what evidence there is and model on that basis, highlighting the uncertainties, or whether the approach would be, well, the clinical evidence isn't good enough, so that's the end of it. But maybe Darius, you might want to sort of comment on that.
Well, I wanted to start, Adrian, with an important point you made, which is indeed the complexity of the U.S. healthcare system and the need for such an agency to serve a very wide range of stakeholders, different kinds of plans, public and private, healthcare systems providers, patients, and all of which have very different kinds of interests and incentives. And overlaid on top of that is uncertainty about real world effectiveness, which this example, I think, crystallizes for us. We have two trials that appear to reach different conclusions. So even before you get to the real world extrapolation, there's debate over the clinical trial evidence. So I think that there would be, and then there's scope for understanding the right modeling approach. And I think here, such an agency has to be cognizant of the fact that there is no single modeling approach that is 100% better than others. So it's really about identifying credible strategies, credible studies, and coming up with a range of possible estimates and values, and helping people appreciate the risk. And what are the upside and downside risks for any new drug? And while this is a salient and high-profile example, in a sense, every drug launch comes with these kinds of uncertainties, that we have to take a pivotal trial and map it into a 10 or 15-year real-world effectiveness estimate. And there's a lot of black magic that us as economists have to cook up in order to get to that estimate, and there's always uncertainty around it. So an honest appraisal of the evidence base we have, the real uncertainty in it, the risks associated with different kinds of adoption or reimbursement or utilization decisions, I think that's the output here. And it's maybe it's not as clean and satisfying an answer as saying the agency is going to name a price, but I think that's because we have this very strong view that pricing is an activity that has to happen in a decentralized system with the organizations, people, and providers that are either using the drug, prescribing the drug, or paying for the drug, rather than a single public agency.
Right, and I think that's an important point that you make, that these conversations, about these innovative technologies, they're going to continue to happen. And I think an interesting point that kind of Lee touched on during his remarks was, right now there's not a whole lot of, conversation about cost in these conversations. And I just wonder, like, is not factoring in the cost of these therapies a sustainable approach given kind of the potential financial implications of some of these technologies, whether they are or aren't effective, and just kind of the financial situation that we're looking at in the Medicare program right now with solvency and just kind of the projections for kind of where that program is headed. I mean, is there some inevitable consideration of cost at some point?
The only thing I can say, because that's obviously a political decision and I'm a career official, is that Liz Fowler has clearly signaled, as has the administrator, of our move to more of a population health, total cost of care approach, and really moving more towards the mandatory models. So within that context, and before I entered the government, I did teach a course on value-based healthcare, and I had an executive, Omar Ishrak, talk about his view of new technologies in his role as CEO of Medtronic, of really developing a value-based contract. Whether that will be adopted by the administration, but certainly as the administration rethinks a lot of the models and how to get us to more cost of care, that may be a more appropriate way. So that, in fact, and that gets back to my first comment, an independent board, some of the coverage decisions would no longer be Medicare fee-for-service. They would be the MA plans or the models. And they would have to decide if the total cost of care, would they adopt the technology, and therefore a group that can look at those questions would be helpful to others, not necessarily the CMS fee-for-service approach.
So, I mean, as I understand it, the proposal in the white paper is for a sort of cost consequences, as in the costs will be identified along with the clinical effects, but then it would be for individual payers or those bodies advising individual payers to package up those numbers in a way that was relevant for that particular payer's decision, or indeed the payers would have their own private sector bodies that the agency would be supporting with appropriate methods and other things. So I don't think for me, I don't want the US healthcare system to be ignoring the issue of value for money. I think the issue is, as I understand from Gail and Darius and Peter, is how do you actually make that work in a pluralist, disaggregated healthcare system with a number of different payers?
I think that's right, and I think circling back also to the point that Lee made as well. This is about value-based decision making, and I think that one part of the motivation for the panel was that we think this is an increasingly salient issue, and it does seem increasingly likely that cost will play a more explicit role in public policy or public health policy in the United States. Certainly more of a role than it has played in the past. The concern, though, there's several concerns about how that'll all play out. One of them is that cost has to be considered in the context of determining value, and we have to really the long-term goal here is to figure out how to move towards a healthcare system that rewards value, both from medical innovators, from providers, from healthcare systems, you name it, and value is defined as according to consumers. That's what economists think. So patients' perspectives on this are critical. So that kind of brings everybody to the table and with a seat at the table. And so this is really about making sure that cost is incorporated in a way that's consistent with value-based care, rather than just as a prelude to blunt cost cutting that penalizes good technology and good care just in the same as it penalizes bad technology and bad care. That's not what we want to have be the consequence of this increasing acceptance of costs in U.S. health policy.
So if I may, I mean, the key would be really making it clear to the innovators what the criteria by which it would be adopted by the community. So, and some of the things in the white paper sort of identify that. And I still remember back to the Blue Cross panel really talking about that clarity that if in the right population you can show value or even efficacy, that's really powerful. Now, there is one other, and I'm being part of this administration, I can't not say that equity is going to be the other question. So as you look at these technologies, will they increase or decrease equality across different populations? And will a particular population with a technology be left behind as we think about it? So certainly, you usually don't think of coverage decisions like technology assessment as a place to put in equity, but I'll put a plug that it is something we are certainly in the agency thinking about.
Excellent. Thanks so much for all your thoughts on that issue. One other aspect that I don't think we've talked about yet in kind of making an agency or a body like this a reality would be just kind of bringing it into the real world. And I guess my question for all of you is kind of whether you see this as something that would need to be outlined by Congress, or whether there may be some regulatory flexibility to kind of do this sort of evaluation within the existing structure and regulatory flexibility that HHS or CMS might have already.
So I guess I'll start being the U.S. As I said, it's very clear that we can use high quality technology assessment as we do our national coverage decisions. Mm-hmm. And as you state in the white paper, this would be informative but not mandatory. So in many ways, if this popped up tomorrow, would we be, and it was high quality assessments, would we be listening to it? Absolutely. Would we be mandated to respond to their comments like we are for the United States Preventive Task Force? No. So and that would be more statutory than regulatory. So it would be more of, are we mandated? It could actually, let me take that back. But the key question is, right now we would, if it was valuable in making the decisions, it would be used tomorrow to inform us. But we cannot substitute our own assessment with it. It would be an important part of our national coverage decisions.
Certainly, I think there are things that could be done, as Lee emphasized, without an act of Congress. But I think it's important to emphasize that a good part of what we conceptualize requires funding to stimulate, for example, assessments in underserved areas of the healthcare system outside pharmaceuticals, for example. So I think that, of course, that unless we're talking about some reallocation of funding that would be done, this requires an act of Congress. And so I think to be really impactful in the way that we envision it, and I think that this is about reconfiguring health technology assessment to be really about health technology, not just pharmaceuticals. I think that would require a commitment of resources and a strategy for an independent body that is insulated from the hurly-burly of payer incentives or industry incentives and such. So I think that we were envisioning an act of Congress for those reasons, but there certainly are specific goals that could probably be achieved without an act of Congress, and that would be great as an interim step as well. And Lee provides some examples of that, I think.
I'm going to pass on the sort of US legislative framework. I just would like to pick up, though, Lee's point on equity, which is a very important one. In fact, there's an ISFOR Value Assessment Summit on Thursday, virtual one, which both Darius and I are participating in. And there's a UK academic there, Richard Cook, University of York, who's going to explicitly talk about work that he has been doing and potentially will be picked up by an ICER as to how one can try and build an equity component into a value assessment framework.
Absolutely. Adrian, I did want to make sure, maybe you can kick us off for, I think, the next question here, which, I think, as we touched on a little bit in the prior panel, like there are some entities that kind of exist in this space already in kind of different forms. None of them are exactly what we're looking at, but we have, PCORI, MedPAC, different branches of CMS that's analyzing this data already. So I think I'd like to just open it up and ask, and obviously there are international kind of equivalents to this too. Like, what are the strengths and weaknesses that we should be learning from and thinking about kind of how the U.S. could be, building its own model and kind of learning from the lessons that, are kind of out there already. So, Adrian, if you'd like to expand upon that a little
Well,
bit.
I think of my sort of two introductory points, I think the most relevant is to have a sort of customer focus, because in a sense it's being able to change and impact healthcare and payer decision making and delivery systems. So it's always being aware of how is that stakeholder involvement built in a way that means the topics are going to be, once the evidence is there, the topics are going to be picked up and decisions are going to be made around it.
And it's ironic that you had Sean Tunis on this panel. And Sean knows the story, but in 1996, Jerry Anderson, who was my economist mentor at Hopkins, took me on a ride over to Woodlawn, where I'm standing now, to talk to Sean to understand, as we created models, how CMS would think about the answer. So I'm just sort of echoing Adrian's comments that, we're not the ultimate consumer. That's our beneficiaries in the American population. But given understanding what our statutory and regulatory framework is, would help us be able to use the information even better. And that's what Sean did for me 24 years ago.
Couldn't have said it better. I have nothing further to add to those great points.
All right. Excellent. So I think we have just a couple minutes left. So I think I am just going to end with sort of a lightning round for, I guess, especially Adrian and Lee to weigh in on kind of the economic analysis portion of the white paper, just because, again, that was something that is hotly debated in Congress now, has been kind of a roadblock for some other institutions in kind of being effective and being powerful and influential in the healthcare policy debate. So I guess my question for each of you is, as you've watched other kind of debates play out, do you think the inclusion of, a metric like the QALY or even disaggregated economic analysis is going to, cause practical concerns for a body like this moving forward?
I mean, I personally think it needs to be there for the credibility of the body. But I think what I'm reading in the white paper is there wouldn't be any single metric that was the only metric that was reported. So again, different groups in the healthcare system might pick up different parts of the assessment and use it in a different way. But it seems to me that that having the QALY there is absolutely essential as one of the outcome measures that would be looked at.
And on a personal level, I think that's a very useful measure since, like others on this panel, have published with it. But I think, as Adrian said, a key question will be just cost, sort of a cost minimization study, because there will be a lot of bodies who are asking, is this going to save me? And how long is it going to save? How long will it take to I actually recoup those costs, given the fragmented American health system? So that's different than CMS, but for like the MA plans and others, they're going to ask those questions, I'm sure. So that's a useful to inform others.
Maybe I'll just quickly say that in addition to the serving many stakeholders, I think this agency also will recognize that the economic science around health technology assessment is always evolving and that it needs to keep up with that evolution. And so that, in a sense, builds in some flexibility for the way health benefits are measured, the way value is assessed, in order to be as useful as possible to a broad range of stakeholders.
You brought me back to the Gold Book. What was that, in the 1990s, 2000 time frame?
I'll end with a shout out to Peter.
Yes, we have Peter Neumann's second edition, so yes, we're going back a long way.
Excellent. Well, thank you so much to all of you for participating and offering your thoughts and insights this afternoon. Unfortunately, we are out of time, so I want to thank you to our authors, Darius, Gail, and Peter. And I also want to thank Lee and Adrian for being panelists and for joining us for a discussion on kind of the ideas that were raised and just kind of bringing some really interesting real-world perspective to those. So on behalf of the Aspen Institute and the USC Schaeffer Center, thank you so much for joining us today. And I hope you have a great rest of your Tuesday.